heart, and so on. So a lot of these signaling pathways come from the brain, go back up, and then go back down again. It's just insanity. There's a few slides here on the thyroid gland. The thyroid in most individuals consists of two lobes, two bilaterally somewhat symmetrical lobes connected by an isthmus region. In many individuals, it doesn't. You should not expect or anticipate this sort of symmetrical organization. Rather, what you'll have are what are called thyroid lingula, and thyroid means tongues, and you'll have tongues of thyroid tissue extending all over the place. Typically, most of us have just one or two of these things extending upward from the medial region of the thyroid gland. Yeah, you can sort of see the lobes and the organization here. And then, of course, posterior to the thyroid gland, you would expect to find the parathyroids, typically 4 of those. So again, the thyroid gland heavily perfused by the thyroid vessels and drained by the thyroid veins. And this thyroid artery comes directly off the external carotid. The only exception to that you need to be aware of, that you should be familiar with in thinking about tracheotomy procedures and cricothyrotomy procedures, a certain percentage, I don't recall what it is, I think it's on the order of maybe less than 10%, like 5 or 10% of individuals have what's called a thyroid EMA, IMA, thyroid EMA artery. And you can see it goes right smack dab up the trachea to the thyroid. So cutting in this region can be responsible for generating copious loss of blood in such individuals. Lymphatic drainage we're looking at here, we have 2 illustrations here. We're looking here most through the posterior, the deep and inferior neck. But they're in general, at least the way I think about this, there are 2 fundamental classes of these lymphatic nodes, superficial and deep. And you can see when they will teach you to do the palpations, you're basically palpating the superficial submandibular and the tonsillar glands. But there are, you can see there are lymphatic glands that are behind the ear and anterior to the ear and so on. And then all of these, as we've indicated before, will tend to drain toward the deeper cervical lymphatics that you can see tend to be clustered around the internal jugular vein here. And then, of course, all of this eventually will go right back into the venous circulation. We mentioned the parathyroids. Usually for some individuals have more, some have fewer. And this is simply, on the right here, this is simply an illustration of where ectopic parathyroid glands may be located. As you can see, they're all over the place. This is the numbers here are the relative incidence of parathyroids. So I don't know what to tell you, except that this can be a cause of calcium mismetabolism too. When you're looking for parathyroid glands, or another thing that can happen is oftentimes when the thyroid gland is moving. We saw in the discussion of the larynx problems before, the fellow had thyroid surgery, and then some vocal problems. Oftentimes they will lift out the parathyroid glands, and we're going to find later they're important for calcium regulation. Well, supernumerary or ectopic parathyroid glands can also can present complications for surgical procedures if you don't expect them to be there, and then that in turn can disrupt normal calcium metabolism. We'll talk more about that later. All right, I'm going to move right on. Our next area of interest here is the back. I won't even ask, since none of you can do a vocal fry, I won't even ask if you have that type of adornment done to your back. I had that done a while ago. It was such a pain, such an annoyance. So when we talk about the back, of course, we're talking about everything from the integument to the subcutaneous tissue. And by the way, remember one of your objectives in here is to be able to specify the tissue layers that are traversed in any type of puncture wound or surgical procedure in any region of the body. But again, the integument, the subcutaneous fossa, the deep fossa. By deep fossa, we're often talking about, for example, the fascia that overlies muscle tissue, which we're going to see later is usually something called scarpa fascia or epimysium. Epimysium is another term to describe that type of fascia. If you've ever observed an animal being skinned, you often see when they remove the subcutaneous tissue, there's this glistening surface on top of the muscle, and that's what you're looking at there. Then the next layer is typically the muscular layer, and then as we proceed into the back, we're going to be talking about the vertebral column and the supportive structures attached to that, for example, the thoracic ribs. At the end here, when we finish our discussion, we'll look at some back surgery, and I want to make sure that you can anticipate and understand all the structures that are being enumerated and moved out of the way or accessed in order for the individual to receive the proper treatment. Again, a lot of these anatomical regions overlap with each other. When we refer to the vertebral column, of course, we're including both the neck and part of the appendicular, lower appendicular skeleton. In fact, when we talk about bony surface markers or surface markers of the back, that would include appendicular structures for the lower limbs and the upper limbs, such as the scapula. But our focus is primarily upon the axial skeleton. The axial skeleton consists of the vertebral array that you see here and the bony protective ribs in the thoracic region. With respect to the functions of the vertebral column, this sort of endoskeleton that both, for example, protects the central nervous system, protects the spinal cord. It also, of course, must have the ability to absorb the entire weight of the upper body and then convey that weight to the lower appendicular girdle. It must be able to provide support for the head, position the head in a remarkably precise fashion. And then, of course, a lot of the structures, a lot of the reason that these vertebrae have the shape that they do is because there are muscles and tendons attached to them that have nothing to do with the back per se. For example, the largest muscles that move the arms are attached to the back. Those are what we call the extrinsic muscles of the back, such as the latissimus, pectoralis. So we're looking at the spinal cord here. As the patient has undergone what's called a laminectomy. Don't guess he's a patient at this point. But here's the spinal cord, of course, and we can see the little roots emerging from the cord. Remember, despite the fact that there are 8 cervical spinal nerves, there are only 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral, and then usually you'll see 4, but I'll say 3 to 5 coccygeal fused vertebrae at the very bottom, so be sure that you can identify these. We'll be talking about a variety of the various processes and the structure of the individual vertebra. The vertebra itself has processes that accommodate muscle and tendon attachment, but it also has facets, unless you are a PA. For some reason, healthcare workers get really haughty in their pronunciation, and you will learn to pronounce facet. And I don't know why. But in any case, when we talk about the facets, we're talking about the articulatory surfaces between adjacent vertebrae. And for the most part, those are called zygapophyseal joints. Zygapophyseal. So what's more satisfying? Zygapophyseal or facet? But in any case, zygapophyseal joints are the joints between adjacent vertebrae. And in the back, that's not the only type of joint you have. You also have joints between, for example, the ribs and the thoracic vertebra, and you have joints between the vertebra and the intervertebral discs. So these zygapophyseal joints refer only to the joints that articulate the adjacent vertebra. The vertebrae themselves count for about 75% of the vertebral column length, the intervertebral disc for about 25%. The problem is, of course, is that with aging and pathology, this 25% begins to change and generally becomes smaller, and it doesn't always become smaller in the same direction. It's not always a uniform reduction such that as one side or the other decreases more rapidly, that can give rise to abnormal curvature of the column. And we'll talk about some of the changes that occur along the length of the column. Of course, once again, be sure you can identify the regions we're going to talk about, and certainly for this test, you're going to have to be able to identify any specific vertebra as either cervical, thoracic, lumbar, and I think you'll find that's a fairly easy task. Now, there are a number of curvatures to the adult spinal column. We talked about a couple of natural kyphoses and a couple of natural lordoses. Kyphoses are the curvatures that are posterior. Lordoses are the curvatures that are sort of, I know I just saying it backward. To me, a kyphosis is this curve that points towards the back, and then the lordosis is the curve that's concave posteriorly, is pointing to the front. So again, lordosis, kyphosis. We sometimes differentiate primary and secondary. Primary curvatures are those that we are born with, and the fetal spinal column is sort of in the shape of a C. Secondary curvatures are those that emerge as we age, as we continue to increase the amount of weight that's placed upon the spinal column. So for example, the lordoses, the natural, tend to be secondary because we acquire those developmentally. Here's the sort of fetal spinal conformation, but this is how we end up over on the left. We mentioned that in some cases the curvatures can become excessive or pathological. You have an illustration here of an abnormal kyphosis, generally due to anterior degradation of the intervertebral discs over time. There can also be problems of degradation of the body of the vertebra, as might occur in osteoporosis. Lumbar lordosis tends to have more mechanical causes associated with muscle weakness, especially in the trunk musculature. There may be problems either with the thoracic wall or the abdominal wall that contribute to lumbar lordosis. But that's the lumbar lordosis there. That's the kyphosis here. Scoliosis may or may not be attended by kyphosis, but implies an abnormal twisting of the back. So you can see that in the example on the right, for example, there's sort of a slight sigmoid shaped laterally, but that's usually accompanied by some degree of twisting, a torque or torsion imposed upon the spinal column as well. And the reasons can be myopathic, once again, developmental muscle weakness. There may be developmental abnormalities in the formation of the vertebra formation and growth of the vertebra. Sometimes a difference in leg length can be contributory. You can see a very scoliotic spinal column there. One student, I don't know if it was in the nursing course or this course, indicated that she had undergone this procedure.
Great sound effects.
A procedure like this is extremely dependent upon the sound effects. Just wouldn't work without
Yeah.
synthesizer.
Exactly. Wow.
So what's the purpose of something like that? What was attempted there? What was the goal?
What's that?
Here they'll try to promote, at the end, they'll just try to promote bone growth around the mechanics. But what was the objective here?
Straightening the
Yeah, to sort
scoliosis?
of provide attention, rather analogous to dental braces or whatever. Stop, I can't take that noise anymore. Yeah. I think either or both would be desirable therapeutic goals. I know in some cases, I have had folks report that it did improve their posture. Of course, a lot of, can you think of problems though? Yeah.
Can you move? I mean, can you bend and stuff if you have a wire in your back? Not
It
really.
would certainly inhibit
Right.
movement, and if you did, what might be a problem there? For example, what is revision surgery? What is revision orthopedic surgery?
They need to go back and fix things?
Yeah, they go back and fix it. Now, you will have no trouble going on the internet and finding revision surgery for procedures like this. Why might that occur based upon what you just said? Somebody may be torquing those rods a little too much, and that could have unfortunate consequences. And again, it makes you cringe, but you'll have no trouble finding those surgeries on the computer. But in some cases, they seem to be very helpful, as I say. With a couple of students over the years who've had procedures of this type done. You've been keeping up with King Richard, who was killed in Bosworth Field in 1485. They recently discovered his skeleton in a parking lot in Britain.
Yeah, they did.
But what do you notice about his spinal column? There was the great King Richard, whom Shakespeare wrote so eloquently, who suffered scoliosis. But I don't think that's what killed him. That seems to be the fatal wound right there, according to the historians. All right, so we talked about the morphology, the shape of a typical vertebra, and what we're going to see there isn't really any typical vertebra, but what they typically have are several processes. There are three major processes in most vertebrae. These are primarily for muscle attachment. We have one spinous process back here and a couple of laterally projecting transverse processes. Then there are going to be additional processes for articulation with adjacent vertebrae. There are usually two processes above and two processes above, or two processes above and two processes below, allowing for articulation between the adjacent vertebrae. And remember, these are called the zygapophyseal joints, and these are generally synovial joints that have the synovial fluid, the joint capsule, the whole bit. And they can become arthrotic like other arthritic, just like any other synovial joint. We also see in the illustration here the relative placement of the intervertebral disc with respect to these two lumbar vertebrae. So that would be the body there, and this is the IV disc, and then the body of the adjacent vertebra. And the blue regions represent the articular facets. Now, in a typical vertebra, here we're looking at a cervical vertebra, but there's going to be the body that you see here, and then you have what is called the arch. And I think you have another illustration here showing the same thing, but this whole thing is called the arch here. Sometimes it's called the vertebral arch, sometimes it's called the neural arch. But the arch then consists of a couple of different components. In the cervical, we don't see it, but it includes the points of attachment called the pedicles, and then you have the lamina that tend to be directed posteriorly. This is a nice illustration showing the sort of division of labor or functional organization of a typical vertebra. The body is for weight support. That's where, of course, that presents problems. This is the region that tends to become compromised if it's osteoporotic or if it suffers from severe mechanical load. And then you have the red region, which is primarily protective of the spinal cord, sometimes called the neural region. We talked about the three processes, the two transverse processes and the spinous processes that provide for muscle attachment. And then the blue here are your articular processes, facets, or zygapophyseal joints, whatever your pleasure. So be able to recognize each of these components. The length of the process will often depend or will often determine the muscular force exerted upon that region of the spinal column. We can see here the intervertebral discs that are so vulnerable over the years, given our bipedal locomotion. We will learn later that the IV disc has a curious sort of target-shaped organization. It has a peripheral annulus, and then there's a sort of fluid interior, which is it's designed or intended to accommodate the changes in the load distribution, but sometimes it can become compressed and lead to structural loss of integrity in the outer bony region, and that's sometimes described as a herniation. So you're familiar with C1 and C2, the atlas, which of course supports the weight of the skull. You can see these are sometimes called lateral masses here. We don't really have a body in the atlas, but you have two openings here. One for the dentoid process, so the dens of C2, and then the other for the other to accommodate the spinal cord. You can see the relative relationship of the two, the atlas sort of pivoting upon the dens of the axis there. Here's the dentoid process and the superior articular facets. Notice that these facets in C1 and C2 are more or less horizontal relative to anatomical position, unlike other cervical vertebrae. So the cervical vertebrae typically have a fairly small ovoid body. You can see the characteristic transverse foramina on either side of the transverse processes. They're bifid. The processes are bifid all around. The spinous process and the two transverse processes have two little projections, with the exception of C1, C2, and C7. All of the others have that bifid spinous process. So we've talked about most of these components. The only thing I can see we haven't talked about is this region called the uncus or the uncinate region. Remember, uncinate means hook-shaped, and that provides sort of an interlocking lip for the adjacent vertebra. The problem there is that in any type of joint disease, that region is the first to become covered in osteophytes. What are osteophytes? Spurs, yeah, bone spurs. That's where the arthritis tends to show up and again tends to further diminish relative motion. So remember, C1 and C2, these articular facets were horizontal, but that's not true of the remaining cervical vertebrae. You have this very oblique, downward sloping relationship between the adjacent vertebrae. And then, at least depending upon, I guess the better way to say this, in the superior cervical vertebra, the spinous process tends to be more or less at the same level and doesn't slope very much with respect to the body. Of course, as we move down to C6 and C7, the spinous process becomes longer and more sloping. By the way, in this little X-ray, you can see the odontoid process there sticking up into the opening of C1 in the atlas. And then in the illustration here, you can see how the spinous processes are lengthening and tending to point progressively more downward as we proceed inferiorly. Again, notice that C7 is not bifid. But should be readily palpable. It should be the most prominent projection up there in the upper back. And you'll often use it as a landmark for that reason.
Here's what the cervical spine looks like in the living body. Here are the spinous processes, the articular pillars, the transverse processes, and the vertebral bodies. The intervertebral joints are here. They're synovial joints. To get a better look at them, we'll make a cut through the articular pillars along this line. As with all synovial joints, each bony surface is covered by a layer of smooth articular cartilage. The space between the cartilages is filled with lubricating synovial fluid. The fluid is contained within a fibrous joint capsule, which permits movement.
Here's that C7. Again, you should be able to palpate that, and that's a prominent bony marker that you'll use for a variety of purposes. Moving down to the thorax, the thoracic vertebrae differ fundamentally from other vertebrae in the spinal column by virtue of the fact that they have to support the ribs. So now we have much longer and more complex transverse processes. The body of the thoracic vertebra tends to have a heart, or I don't know, I would say probably a ovoid shape as well. And the other characteristic is, notice this spinous process is much more downsloping relative to the body. We now have, unlike in the cervical region, we now have fairly distinct pedicles. Again, all of this is the lamina. Here are the pedicles here. And so in addition to the articulatory surfaces for the adjacent vertebra, you also have costal facet surfaces to accommodate the attachment of the ribs, both proximally and distally. Here's your costal facet back here and the transverse costal facet at the end of the transverse process. Again, notice the remarkably downsloping spinous process.
Each of the thoracic vertebrae articulates with a pair of ribs. On each side, the vertebra articulates with the rib at 2 points. Here, at the end of the transverse process, and here, where the pedicle meets the body. We'll be looking at the ribs in the second section of this tape. The transverse processes of the thoracic vertebrae point sideways. The spinous processes point downwards, each one overlapping the one below. The articular processes are almost vertical. The upper ones face almost straight backwards. The lower ones face forwards. There's only a little movement between thoracic vertebrae, partly because of the presence of the ribs and partly because of the way the spinous processes are arranged. The movements that are possible are small amounts of forward flexion, lateral flexion, and perhaps surprisingly,
What is he doing there? I didn't edit the tape very well. What is he doing there? What's rotation? Yeah. The thing I wanted to go back
Get
to.
a
Stop. As you look at, let's see if we can get it just a little further there. This is a nice visual. This is called the intervertebral foramen. We'll talk about that in just a moment. This is where the roots and the nerves emerge. Here's the intervertebral disc. So if you do have collapse, herniation of the intervertebral disc, is it clear if it goes posteriorly, if there's herniation posteriorly, that can impinge upon this neural pathway here. Of course, there are blood vessels and other structures passing through there as well. I'm going to come to you for back pain, and I'm going to require that you perform the back surgery. What are you going to have to do to get to the, first of all, you need to, as you look at a structure like that, be able to tell me where the spinal cord is located. And then you need to tell me how you would access it. How would you go about it? What structures, what components would have to be removed, if any? It all depends. Would you think you'd do that in the thoracic region? What would you have to deal with? Yeah, the lumbar. So we're in the thorax, and it probably wouldn't work. That approach wouldn't be ideal in the thoracic region. But what's the problem back here in the thoracic region? That you don't-
Spinous.
Yeah, these things there. This looks pretty grim here, but I have seen, I'm certainly not an expert on this topic, but I have seen translocations of that, what seem to me of comparable magnitude, and then you'll read slow recovery following reduction or something like that. So I don't know the outcome in this particular case, but when we talk about thoracic fractures, this would be an example of that type of phenomenon. And of course, depending upon the degree, the magnitude, you would expect the patient to exhibit to pain, perhaps loss of function. We talked about the degree of injury is dependent upon the level of the spinal cord injury. We talked about hemiparesis and hemiplegia, for example. So you can have a loss of sensory or motor function on one side, both sides, if it's incomplete, or there can be just motor or sensory function compromised on one side, depending upon the location and the angle of the injury. This was in Naples. Excuse me, as I thought there was. Well, it's gone now. So let's move on to the lumbar vertebra. I'm not sure what's going on. So, of course, if you look at the lumbar vertebra, you can see they're much more massive. These are the most massive. They bear the greatest weight. The bodies are larger, sort of rounder. Sometimes you describe as a kidney shape, but I just sort of see it as much more spherical all around, much more block-like than the thoracic vertebra. The processes appear, both the spinous and the transverse processes appear relatively short to the body, but in reality they're fairly long. They're certainly proportionately shorter, but they're massive in the thoracic region. I'm sorry, in the lumbar region, because of the very powerful muscle attachments for both extrinsic and intrinsic muscles in this region. You will notice, maybe if we think about problems associated with accessing the spinal cord in this region, at the very least, you don't have to deal with a long downsloping spinous process. It's rather blunt and short, at least proportionately. And the articular facets, that is to say the facets that join the adjacent lumbar vertebra, uh, these are called mammillary processes up here, are again stout, and their general function is to inhibit relative movement. Unlike in the cervical region or to a lesser extent in the thoracic region, these things, as you can see, are more or less aligned vertically, and their whole function is to prevent or at least minimize relative movement. We talked about the intervertebral foramen. The intervertebral foramen is formed from the superior and inferior vertebral notches of adjacent vertebrae. So I think you'll have no trouble differentiating a thoracic vertebra from a lumbar vertebra. Here's a slide, though, to facilitate that task where you can see the two side by side. Now, of course, most back pain issues are in the lumbar region. As you look at the lumbar vertebrae and the intervertebral disc, and for that matter, its union with the sacrum, why would you suspect an increased incidence of problems in this area? Any structural engineering issues? Which way is the weight coming in? Coming. All right. And yet these things are turning. What might happen as a consequence? You know, there might be extrusion, increased, an unequal or incongruent allocation of load on the intervertebral disc. This is the most common location of herniation, and generally when this structure gives, this outer bony region of the IV disc, it's all I say bony, it's all fibrocartilage, but when it yields, it's going to go to the path of least resistance, which is oftentimes posteriorly. By the way, so as we're going to find, the IV discs consist of a central fluid or jelly-like region and a fibrocartilage perimeter. The body of the vertebra also has two different consistencies. The outer region, the outer annulus, is rather dense, compact bone, much less so in the interior. So generally in osteoporosis, you see a loss of bone density proceeding from the interior of the body to the perimeter. So this is a nice illustration, as I would encourage you to think about how you're going to alleviate my back pain. You need to be able, as you look at a structure like this, to tell me in the lumbar region how you would access the source of the problem and how you would avoid doing more damage than is already present. So what is added? What other problem has been added to our list of issues to deal with and trying to address my back pain here? What's this thing in here? It's a ligament. And in fact, there's a whole series of ligaments that are just draped, wrapped around all these vertebrae. We just see one here, but that's going to be very important as it turns out. Here we talked about the intervertebral foramen. We'll come back to that. Moving on down to the sacrum. The key thing to keep in mind about the sacrum is its remarkable shape. Notice it has an almost C shape. It has a dramatic curvature. It's sexually dimorphic. Males have a larger sacrum, but the female sacrum tends to be broader and shorter. And it also has a different curvature as well to accommodate the birth canal. Notice that the anterior curvature is concave, and these are called the anterior foramina. You can see the paired foramina on either side, and that Between these two foramina, you have these little ridges here that, again, characteristic of the anterior surface. Sometimes called just the transverse ridges. You can see how the sacrum joins the ilium there, forming the sacroiliac joint, which there shouldn't be relative movement, but sometimes there is. You might be asking yourself, what do you do in a case like that? The patient has pain in that joint. How would you address that? But anatomically, just be familiar with these foramina. What's the purpose of these holes here? Yeah, neural and vascular structures emerging both on the anterior side and on the posterior side. If you look at the posterior side, you don't have so much the ridges, but what you have are the crests. Sometimes you have one here, sometimes you have 2 or 3 crests. Sometimes these crests will be elongated, so highly variable appearance. I liken it to the skull of a Klingon. These, of course, are the posterior sacral foramina. Now, be sure you keep in mind how these foramina relate to the interior anatomy here. At this region of the spinal column, there is no spinal cord. All that you have, or what are left, are vestigial components of what's called the cauda equina. We'll talk about that more later. But these are just roots that have spinal nerves that have emerged down or following down the interior cord. They get to the sacrum, and the little yellow dots that you see there are all that's left. And then they will emerge in more or less pairwise fashion on the right and left to form these anterior and dorsal peripheral nerves.
Lastly, we'll look at the sacrum. Besides being the lowest part of the spine, the sacrum is also an important part of the pelvis. Here's the sacrum together with the coccyx. The sacrum is formed by 5 vertebrae fused together. From top to bottom, it has a marked backward curve. When we're standing upright, the sacrum is oriented just as we see it here. The upper part of this backward-facing dorsal surface is angled at about 45 degrees to the vertical. The upper part of this forward-facing pelvic surface is more nearly horizontal than vertical. On the dorsal surface, there are 2 articular processes for the 5th lumbar vertebra. The lowest intervertebral disc is quite wedge-shaped. Its shape accounts in part for the very marked curvature of the spine between the 4th lumbar vertebra and the sacrum. The most anterior point on the sacrum is called the sacral promontory. The vertebral canal continues down the back of the sacrum. From within the vertebral canal, the anterior rami of the spinal nerves S1 to S4 emerge from these pelvic sacral foramina. The posterior rami emerge from these dorsal sacral foramina. Vertebral canal ends at this opening, the sacral hiatus, that's shaped like an upside-down V. This curved auricular surface articulates on each side with the upper part of the innominate bone, or hip bone, to form the pelvis. The joints between the sacrum and the hip bones are the sacroiliac joints. These joints permit almost no movement. The broad ridge on each hip bone adjoining the sacrum is the iliac crest,
Which we'll talk about later, but as we go back to his pointing to this structure, this sacral hiatus, he talked about the neural canal or the vertebral canal, and of course what's filling that? Nothing more than little filaments, or what's going to get called kind of basically just nerve roots. And then some of those actually emerge from this point as well. But I guess my question for you, as you look at this structure, If individuals have pain in the lumbar region and even up there at the SI joint or even where the lumbar region joins the sacrum, what is the source of the pain if there's no spinal cord? And if there is a herniated disc, what's it herniating on if there's no cord there, and why would it matter? Yeah.
There's impingement on the most inferior part of the cord, causing radicular pain down those nerve fibers.
Well, when you say those nerve fibers, what nerve fibers?
The caudal fibers descending from the base of the spinal cord.
I'm sorry?
Those fibers descending from the base of the spinal cord.
That's what I was hoping somebody would say. No, those actually those fibers. If you think about it, they're a little bit like the brain. For example, there's no particular pain sensation to be associated with poking and poking around in your brain. Likewise, your spinal cord, and the issue of pain inside that vertebral canal or that neural canal is a subject of much debate, but probably that is not a significant source of pain. Bob, what were you talking about when you said?
Don't the disc impinge on the spinal nerve?
Yeah, well, okay, when you say impinge on the spinal nerves, again, the nerves conduct pain sensations, but they don't probably generate it. Everybody see what I mean by that?
Mm-hmm.
So what's actually generating the pain sensation? What do we need for pain? Nociceptors. Now, where are they? Well, they could be, and we'll talk a little bit about that, but probably a greater source of the pain would be in the meninges that encapsulate all of this tissue. So I just want you to be thinking, again, there's a reflex for all of us to think that herniation, extrusion of the nucleus pulposus into that canal or in some other structure, pain because of the deformation. No, that's not it. And in many cases, you will not know as a PA, you will not know the precise cause of the pain. You're only lucky if you know where the location is and you just sort of follow what the traditional empirical procedures have been developed that sometimes work and sometimes don't. All right, we'll pick up there next time, Wednesday. We'll come back later for physiology.